And I don't have to go into this level of detail for the whole thing, but I'm just like asking because this is literally the conversation that is fun for me to have. That's what my whole show is. It's like the conversation I want to have. So, and then somehow I convince you to having this conversation with me. So nobody to blame but yourself. So
Gotcha.
How does your first assist retract the duo medially while you're holding a DeBakey and a cautery?
Well, they're both women. They're fantastic. And she just sort of, I get into that initial plane. I just break down that initial peritoneal attachment myself. I just kind of get in there, and then it kind of creates a little shelf for her to get her fingers into, and she can just keep pulling it up and keeps adjusting. And I swear she has like 15 fingers because like they are exposing everything beautifully. And so, yeah, it's just, and then sometimes it's, that's not what I need to see. And I just take her fingers and it's almost like having my own new retractor on the book Walter. And I kind of put her where I need her and I pull her back and then I get going again.
Do you, once you get a little bit of, traction, so to speak, with the same person over and over, then it's easy. But do you have any way to teach a new, assistant how to be a better assistant? Because I have one thing I tell them to be like Gumby. Yeah. Some people get that and some people don't. Yeah. But any other tips like that and how you can, because everybody has this same problem, whether you're doing Whipples or you're just doing lap choles.
I remember so for the longest time when I started doing Whipples, I was using one of my partners who soon afterwards retired. And in his retirement, he offered for us to maintain his malpractice insurance so he could keep assisting us with a variety of surgeries. My one partner used him for esophagectomies. I used him for Whipples, and we'd call him in the middle of the night for traumas if we needed him. And eventually he's like, Kate, I'd really like to retire. I've got some grandkids and, I'd like to travel the world with my wife, and you are good enough and should do this with first assists. And I was terrified. Like, how was I going to do that the first time? And so I kind of found like the perfect first case, like that non-cancer. There was going to be no vein involvement. There was going to be, not a lot of hypervascularity or desmoplastic tissue and things like that. And I just said, this case is going to take a really long time. And, and we just had to be patient with each other. And in that way, like I've worked with a few different RNFAs, and eventually I told the OR, like, these are the two that I have to use that listen to me, that understand, and that I can work with. But I have to tell you, it's hair raising. When you're in rural America, you don't have you don't get your own team for every case, right? You get whoever's there, and they may be travelers, and maybe they've seen a Whipple before and maybe they haven't. And you really have to embrace your role as a teacher more than anything else. You can't be upset that they're not reading your mind. Yeah.
Okay. So patience and communication. Okay.
That's really everything, right? I can't tell them, I can't sit here and tell you like, this is how I tell them where to put their fingers, No, you have to be in the moment and then be like, no, this is what I need from you, and kind of adjust it.
Well, that Gumby thing, that's literally something that I tell everybody, and then if I have to explain it, like, you move when I move you, don't be so rigid, but then stop and don't move again, but. Yeah, no, you have to, and eventually you work on their ability to anticipate, and eventually you let them grab the portal vein. Okay. So maybe we talk about vein recon in a minute, but so we got your Coker maneuver completed. How do you know that your Coker maneuver is completed?
Oh, I should be feeling the spine. I should be up and over that vena cava all the way through. And I should be almost, if not completely, through the ligament of Treitz. And the thing is, you want to do it all up front when you are fresh and you're excited about your case, and not realize that 4 hours later when you're coming across your uncinate and peeling it away from the SMA that you just didn't quite do enough at the beginning and then have to redo it. Like you so much of what we do is getting a step done through completion on the first go around. And so, your Coker maneuver is complete when you go from your ligament of Treitz up to your porta, all the way over the IVC, and you're back to the ligament of Treitz up to the porta, over the IVC to the aorta. Okay.
I never really considered doing Whipple as part of my practice. So I did, I think I graduated with 9 pancreas cases as surgeon junior, and had, but we were HPB center, and that doesn't count, obviously, the ones that I didn't do a meaningful part of the case that I put as first assist. But man, it's like starting to take me back a little bit. So I'm coming up on 6 years out of residency.
I got to tell you, like, knowing those techniques, I mean, as a rural surgeon, like being comfortable in that part of the body helps you with your perforated DUs when they come in and you got to fix them. And it's even helped me through a couple really challenging traumas, gunshot wounds and things like that. Like the Coker is the beginning of a total medial visceral rotation to that side and how you evaluate the IVC. And I think it was when another surgeon called me in to help with a case. And I said, I'm used to getting called in anytime somebody looks at a pancreas wrong in the OR, but this had nothing to do with the pancreas. And I didn't say, like, why am I here? But I was kind of curious. And they said, if you're a pancreas surgeon, you're kind of the queen of the lesser sac. If I need you, and I was like,
Straub,
I guess that makes sense. No, they were having a vascular surgeon was in a dicey AAA and they needed supraceliac access. And they were just like, we want somebody who's, our vascular surgeons don't go up there anymore. So they were like, we want you here to do that. And, my partner and I just repaired through and through injury to the vena cava from a gunshot wound and got her shipped elsewhere afterwards. But it's knowledge of that retroperitoneum that gives you a comfort level. And you know how aggressive you can be and how far things can go and what it's supposed to look like.
You have a lot of that gunshot wound trauma in Wenatchee, Washington?
No. So when it happens, it's pretty terrifying.
Sure. Yeah. Okay. So let's get back to the case. So your Cokerization is complete. Next is opening up the lesser sac. You pick up the stomach, you pull down on the colon, you preserve your gastroepiploic artery, and you enter your lesser sac just along that greater curvature and allow the whole omentum and colon to fall down into the lower part of the abdomen. And you open up that lesser sac along the greater curvature, sort of just up past the insensura. And then you should be just staring at your beautiful pancreas at the bottom of the lesser sac. I mean, there's some adhesions in there sometimes. Some people open the lesser sac the other way and let the colon fall down and the omentum go up, or?
Yeah, that just creates too much, tissue in the upper portion of the abdomen where I'm working. The way I do it just allows all that omentum to be in the lower portion of the abdomen. And I'm not trying to retract all that while I'm working on the pancreas.
But some people do that, right?
Not in my practice, but I mean, I'm not with every HPV surgeon.
Yeah. Okay. Sounds good. I'm like kind of operating on memory here. So anyway.
I could see that you're back in your chief year reliving it right now.
Exactly. So carry on then.
Yeah. So from there, you should be able to hold up your transverse mesocolon and kind of see your middle colic pedicle kind of coming down. And that should sort of tangentially sort of ride on top of the SMV. And so what you're going to do is find the right lateral side of your SMV where it's kind of running right along that unsnip process. And you want to get right on that vein and just sort of trace it all the way up to the inferior border of the pancreas and where it starts diving underneath. You open up the inferior border of the pancreas enough so that you're not just digging a deep hole. And then you start lifting up that inferior border and just bluntly, making that terrifying tunnel underneath the pancreas where there should not be any bridging vessels. And there frequently is not, as long as the cancer is not super close to that area. And you can usually make your tunnel. And for me, it's just, a vein retractor on the inferior border of the pancreas and met scissors, just sort of like occasionally snipping these wispy things and just bluntly dissecting all the way underneath to the superior border.
I remember a curved peon clamp pointing upward. Do you use that, or mostly
you can do that too? Sometimes I get a little mixture, those big right angles in there, and kind of just sweep it back and forth. There's a lot of different ways to do it, but I think again, when you have to get used to the efficiency of not having a lot of talented assistants, not to put down my RNFAs, they're amazing, but you do a lot of dissection with scissors. Use your scissors as your blunt and sharp instrument because it just keeps you efficient. Yeah. You treat it like a peon that can also cut things.
Yeah. Okay. And so then you got, say it's stuck. So
yeah, then I have to figure out how stuck is stuck. And is it stuck in a way where this is unresectable? Occasionally we do back out. I backed out last week from one that was wrapped around the hepatic artery. Or is it stuck in a way where it is resectable? Am I going to be able to do a vein resection? Or is there a chance that all this is a desmoplastic reaction from the chemo effects on the tumor, and it's just sort of post-inflammatory changes that have it be stuck? And that can be very, very, very hard to tell.
Do you use frozen to help you differentiate that sometimes?
You do. Yeah, you can. Though, honestly, there's limitations to what frozen can tell you. I mean, if there's vague atypia, you don't know if that's because it's desmoplasia or if you're dealing with real cancer. If it's cancer, it's cancer. If it's not, it's not. But there's a lot of in between that frozen gives you, and you just have to know what you're going to do with that answer when you get it back. So and thankfully, you have 20 minutes to think about it.
Sure. That patient that has an encased hepatic artery, so they're that's it, right? They're not gonna ever have any operation anywhere else.
No, I mean there are some people that are doing some pretty dramatic things in that regard. However, this gentleman had already had a significant amount of liver dysfunction related to his obstructing tumor. Wasn't getting good recovery of that liver function even with stenting, and so wasn't going to deal without hepatic arterial supply. Right.
Okay, and then. Say that it is, so it's borderline stuff. What sort of vascular reconstruction will you undertake?
Yeah. So first and foremost, when I'm evaluating patients, if I say hands down, you're going to need a portion of your vein removed, I'm probably sending them elsewhere. I'm sending them somewhere where they're ready, because I think that every pancreas cancer case, whatever the imaging shows you, it's going to be worse when you get in there. There's no time where I'm surprised at how great it is after seeing concerning imaging findings. So the ones that I'm taking to the OR are the ones where either I don't think it's going to be on the vein based off of the imaging, or if it is in a favorable part of the vein. And for me, that is portal vein or proximal SMV. I do not operate on lower SMV down by where it starts to send off its tributaries. That is just too narrow a vein, and you really worry about boxing too many branches from the small bowel. So I'm picky about which of those cases I keep. What I can do is, I can get proximal and distal control on the portal vein, SMV, IMV, and middle colic veins, utilizing usually just red vessels, folded back on themselves, and use my vascular set to either get good clamps on all of those, or put a Statinsky clamp just sort of around just that knuckle that's frequently stuck to the vein, and then cut it and then suture it back up and cross my fingers.
But you patch them?
I don't patch. No. Again, if a lot of the data shows that you don't need the vast majority of these side bite resections, or even full thickness portal vein resections, don't require much of a patch. You can really mobilize and kind of pull things together. I've never had to patch, but again, I'm picky on who I keep.
Yeah. We're only talking about ones that are borderline, and then it's sort of like you weren't planning on doing a resection, but then you ended up doing it. And so when you're going to close that vein, you're closing it transversely?
It really kind of depends, No, most of the time I'm not closing it transversely. Just the way it comes off, you're closing it longitudinally. You're seeing mild narrowing to that vessel. I've never had issues with postoperative DVTs portal vein thromboses and things like that.
And then afterwards, so you heparinize them before you get started on that part of the case?
If I'm getting full on proximal distal control and I'm tightening things down, they're getting heparinized. If I'm just putting a Statinsky across and there's still good flow throughout, I'm not always heparinizing them.
And post-op then? What do you do with
post-op? They get started on Lovenox right away. You can get a Doppler of the flow.
Prophylactic Lovenox?
Yeah, just prophylactic Lovenox initially, but we do cancer dosed prophylactic Lovenox, and then usually get Doppler in the first day or two just to make sure that there's good flow.
Tell me what you mean by cancer dosed prophylactic Lovenox.
Well, usually, it's 40 a day for regular, and I do 30 twice daily for the vast majority of cancer patients.
Okay, got it. So 30 BID Lovenox.
Yeah. Okay. And they go home on that.
Okay, for a month or?
Yeah.
Okay. So for this listener who is concerned about oral boards, tell me about what they need to know about the topic of resectability of pancreas cancer in 2026. Should they be asked about it on an oral board scenario?
Oh, God, that sucks. It sucks because, I still think there's a lot of people doing a lot of very heroic things in regard to pancreas cancer resection out there. And I don't want to belittle what people are capable of doing.
First, let me pause this just 1 second. Tell me where we came from, maybe. Yeah. And then where we're at now, and like what is like the middle of the road right answer?
There's no right answer. So where we came from, when I was training and maybe when you were training, it all had to do with a degree of involvement of the portal vein or SMV. And if it was greater than 180 degrees, it was probably unresectable. And if there was arterial involvement, it was unresectable. And obviously if there's metastatic involvement, it's unresectable. And now I've learned to not really call anything unresectable if it just involves the portal vein or SMV. What I do is I always try to follow when I send patients elsewhere for second opinions. I either reach out to the surgeons or I review their notes. And what I'm seeing time and time again is, hey, we'll just give you chemo and see what happens. We're not calling anything unresectable in regard to portal vein anatomy now. And unfortunately, a lot of those patients, they had aggressive tumors to begin with, and they just don't go on to formal resection following neoadjuvant. So you say, this might be resectable, let's give you chemo, but most of those patients don't go on to getting it. So things that I still consider unresectable is involvement of the celiac plexus or the SMA or the aorta. That is just unresectable. But when it comes to venous resection, people are being more and more aggressive with what they're willing to offer. And I don't think anything is necessarily considered unresectable. That being said, most of those people don't go on to resection just because they have aggressive tumors to begin with. So what do you say on the boards if you get that question?
I mean, they may just say, well, you got this pancreas mass. This looks like cancer on CT. They make you work it up a bit. So then I would say the right answer is probably an EUS with a biopsy.
EUS with biopsy. And once it's biopsy proven, they get neoadjuvant chemotherapy and you go from there.
Yeah. And then lab wise, they got to get some special labs on a workup.
CA19-9, preferably done both before and after they get their ERCP. They always get it beforehand, but CA19-9 is artificially elevated by biliary obstruction. So you want to get a new baseline after their bilirubin has dropped down.
And then say the mass was like touching the portal vein over just 30 degrees of the portal vein. Okay.
Yeah.
So those people are and always have been resectable. Right. So, but then say it was, and so then the oral board person should, say that they get the workup and the treatment and then surgery, just like that, as long as there's no progression. But then if they got I don't think they would give you this patient, but say it was, 3/4 of the way around the portal vein. So they're probably not going to give you that.
No, they're not going to. And I have to say, I really, as I'm thinking through your thought processes here, I really don't love the term borderline resectable. I feel like things are either resectable or they're not resectable. And if they're resectable, it all depends on how they do on chemotherapy and who the right surgeon is to attempt that resection. Borderline resectable, I feel like should go the way of the dodo.
Sure. Okay. Thank you for clarifying that. And then the last thing I wanted to do for the listener is say somebody's never put a vessel loop for vascular control around a vessel before. Tell me exactly how to do that. So
what you want to do is be as on the vessel as possible for all of this. I think for when it comes to these bigger vessels like the portal vein, it's a little terrifying to be vessel on. You always want to be a little bit farther away, but that's where the dissection plane is. So you want to be right on the vessel. You want to come around the vessel and sort of be able to spread with your right angle or your tonsil to make sure that you have a nice plane underneath. And then you're going to pass your red vessel loop around. You're going to put your clamp back on. You're going to pass the red vessel loop again. So it goes around twice. And then you're going to be able to cinch up on that with a hemostat and occlude the vessel. And you're going to do that on every vessel that's coming in and out of your area of concern.
So a double pass with the vessel loop, and then to keep it while you're setting up all of your 5 vessels that you're going to isolate, you just keep it
them all
loose.
loose. Yep. And then you kind of decide as a team you're ready to go forward with that.
Take your right angle, pass it right under, pull up on the loop that you just passed around, and then clamp all 4 pieces together. Okay. This is how it's my show, Cate. So if I have to ask these stupid questions because I really want to, then I guess it's my right. Thank you for playing along. Okay, great. So then you're going to transect your stomach first, right?
Yeah. Mm-hmm.
And you're going to do that with a
stapler.
GIA.
Yeah, GIA, or now we have to call them linear cutters, but yeah, GIA stapler with the blue lid.
I do not. Stapler.
Sorry?
You don't staple open surgery with laparoscopic stapler.
No.
Some people do that because there's 3 loads of staples on each side. No.
The only time I do that is if I happen to be doing an open distal pancreatectomy. I really like the laparoscopic stapler to staple the pancreas there, because you in general have you can sort of sequentially squeeze down on it really, really nicely when you're doing that. And it kind of allows the pancreas juices to go out, the edema to go out, to get a nice, better seal on that. So when I'm doing a distal, I really love the laparoscopic stapler.
Yeah, I worked with some surgeons who like to use laparoscopic staplers on everything because they have 3 rows of staples on each side instead of 2. But I don't know if that's been proven or whatever. So probably not. I'm sure it's not. So blue load, you transect, however, what length of a stapler do you normally use, and how many loads do you normally have to use to get across your stomach?
First and foremost, I do a traditional Whipple. I don't do pylorus preserving. So I'm going just above the pylorus, but the vast majority of the time it is a single fire of linear cutter 75 with a blue load.
All right. And then you're going up to your porta next.
Yeah, I've usually done my whole port because, again, I don't want to start transecting things until I know everything is resectable. So I've probably done
comes down first.
Gallbladder comes down. You open up the porta. You identify all of your hepatic arterial anatomy, pretty much all the way back to the celiac, so you can pull those lymph nodes over. And then the next step is to identify your GDA and take your GDA. And usually your portal vein, once you take your GDA between clamps, and one trick is, the dreaded GDA bleed, which I've seen twice and is terrifying. And thankfully both patients survived. IR is going to be your friend for controlling that bleed, and you can help them a lot by putting a clip on that GDA pedicle, because then they can see that when they're in there, and they can really identify if that bleed is not actively bleeding, where they need to be throwing their coils. And so right under that GDA, you should be staring at your portal vein, and then you can kind of connect your tunnel from above and below without too much difficulty. Come around the portal vein with a red vessel loop, sort of separate it away from everything else and kind of identify where that is. And once you're there, that's when you transect the stomach. Then I transect the bile duct. I send a frozen section on every bile duct. Then I transect the pancreas, which is a challenge, and always send a frozen section of the duct of the pancreas as well. And then you really want to make sure when you're transecting your pancreas that you're giving yourself an especially good landing pad for your anastomosis. You don't want to be cutting through it tangentially, leaving yourself as sort of like something that's going to be hard to then sew to. You want to make sure that as you're trying to cauterize any bleeders on the edges of the pancreas, that you're not cauterizing too close to the duct. You want your duct to be freaking beautiful. When you're getting ready to sew it again. So you just try, what I usually do is have my assistant put a Raytec over the distal pancreas, the part that's going to become part of the anastomosis. And while I'm getting my frozen section and controlling bleeding on the specimen side of things, she's just holding consistent pressure. And in all the time it takes to do that, that will stop the vast majority of slow oozing from that distal edge, because she's been putting this constant pressure on it, and then hopefully really limit the amount of cautery I need to do to that distal edge.
Do you use some bipolar for the cautery if you need to, or do you just use straight cautery?
I use straight cautery, and if it's bad enough, especially around the edges, I'd rather use stitches than just keep burning the crap out of the pancreas.
Right.
You know, I don't really want that at all.
Landmark wise, for all three of those transections, so how far, for easiest one, stomach, how far above the pylorus do you go?
I'm like a centimeter or two above the pylorus, as long as the tumor is totally uninvolved in that area.
And then how do you know where to transect the bile duct?
Well, you know, especially if you're just dealing with a pancreas cancer, not a cholangio. I don't do a ton of cholangios here, but usually I'm just kind of at that superior border, maybe, you know, right at where the duodenum comes into the where the bile duct comes down to the duodenum, superior border of the pancreas.
Relative to the cystic duct?
Well, the cystic duct is a very variable insertion along the common bile duct, so it's hard to say relative to that. But sometimes being at an area, especially if you have a smaller bile duct, it can be helpful to be up by the cystic duct, because you can almost, you know, when you're doing your reconstruction, you can almost, you know, complete that common septum between the common bile duct and the cystic duct and use that to make a slightly larger anastomosis for your bile duct.
Okay. So would you say that it's commonly around the junction of the cystic duct and the...
I'm a little below the junction of the cystic duct with,
Okay.
With that. But I mean, again, that's variable. The cystic duct can attach in all the way down in the pancreas, you know?
Sure. And then for when you decide where to transect the pancreas, you have, Go ahead.
So the best place to transect the pancreas is over top of the portal vein. I mean, I keep it simple with patients. I draw my pictures and I say, you know, this is where I transect the pancreas. If your cancer lives on this side, you get this surgery. If it lives on that side, you get that surgery. But reason why it's best to transect over top of the portal vein is the pancreas is always thinner there. You know, you're not dealing with a lot of extra parenchyma. So unless your cancer is not letting you transect there, you know, if it's just sort of straddling that neck a little bit, I'm transecting right over top of the portal vein every time.
Okay. And then you have to transect your jejunum.
Yeah, you have to. So then you get to take a break from all the madness that you've been dealing with up there. It's kind of nice to go to a nice virgin part of the belly for a little bit. Hopefully you've done a lot of your cochlearization, so you're almost all the way through that ligament of Treitz. You pull the colon up into the upper portion of the abdomen. I usually measure down to just about that first tributary. You want to make sure that wherever you transect your jejunum, that your distal jejunum has enough flexibility that it's going to easily come up and sort of recreate that C shape up in the upper part of the abdomen. So you want to get away from that part of the ligament of Treitz and that first bit of the jejunum where the mesentery is really, really thick from being tethered down there. And that's usually about 20, 25 centimeters away from the ligament of Treitz. Linear cutter 75 because I already opened it. And so I just use another blue load on that. And then I usually use my, I do use a lot of ligature, Maryland short-handled ligature, and I kind of take down my mesentery with that. I stay very close to the bowel. I don't want to risk getting into that first jejunal branch that kind of wraps around the SMB and comes down to the rest of the mesentery. And then take down the retroperitoneal attachments of the ligament of Treitz until the whole thing just wants to kind of slip up into your upper portion of the abdomen again. And then once you've kind of pulled that through, hopefully most of your specimen is almost on a pedicle of just the unsnit process coming off of the SM, where it's attached to the SMA. And so you start sort of peeling your portal vein and your SMV up and kind of dissecting sort of along that unsnit process as it comes along under there. And barring any vascular involvement, there should just be a couple tributaries from the pancreas to the portal vein that you have to take. And then you want to really make sure, because your unsnit margin is one of the only margins you have really good control, not good control over, but your pancreas margin is important, your bile duct margin is important, and that unsnit margin is important. And you've probably had frozen sections telling you you're out of the woods with the other two. And the unsnit is just this one that you really got to be careful of. And there's usually a really good groove if you've done a good coker off the SMA along the unsnit, and you can just sort of fire your ligature along there and free it up. Makes it sound easier than it is.
Yeah. All right. And then you send the specimen off, any stitches or labels or anything, they can pretty much figure that one out.
Yeah. Well, first I do, I labeled pancreas duct, bile duct, and unsnip process, but almost every time I go to path the next day and I gross in my specimen with them and I make sure that they're getting all that right. I'm in the path lab all the time.
Okay.
Yeah.
And then you bring your bowel up through, and it hopefully is all free. And I thank you so much for explaining the why behind what you're doing and not just telling me exactly what you're doing. So keep that up. And then if you have to make 3 anastomoses. So
pull up your limb of jejunum. You've got your 3 anastomoses left to do, and you're going to start with your toughest one and go to your easiest one. The pancreas is by far the toughest anastomosis, and by the time I get to the stomach, I'm pretty relaxed. So basically I do an end to side anastomosis. I put some corner stitches in, held loosely, just to kind of line things up. And I do a single sort of horizontal mattress suture that kind of lines up my posterior pancreatic wall with my jejunum and kind of takes some of that tension off. I boat the suture a little bit so it does a nice big horizontal mattress. And then one of the keys that I learned from Dr. Al-Sayedi is when you make your tiny little enterotomy and you bring up your mucosa, it is so important that you get your mucosa of your small bowel and your mucosa of your duct to approximate. And it can be very, very hard when you're taking these minuscule bites to make sure that you're getting that. So I actually pull that mucosa out of my small enterotomy and I tack it out onto the bowel in 3 places, essentially, or 4 places, essentially turning it into a tiny stoma. And so that you just have really good mucosa. And I think this has really helped me from sort of backwalling or grabbing the wrong mucosa from the other side and sort of like closing off my ductotomy. It's just kind of given me really good landing sites for my sutures. And then the vast majority of pancreatic jejunectomies are performed with about 6 4-0 PDS sutures interrupted. If it's a really big duct, it might be more, but the vast majority of them are about 6 sutures. And then I kind of do a running silk to sort of pull the anterior border over to the jejunum and kind of take pressure off of that ductal anastomosis.
You said you put 4 stitches to kind of approximate things. What are those stitches to?
So the 4 stitches, it kind of creates, like I said, this little tiny stoma around the enterotomy. It kind of pulls it out and kind of like pulls that mucosa out so you can just see it beautifully. Most of the time when you make that tiny little enterotomy, the mucosa dives back in.
But I thought even before you're talking about setting it up, do you put some stay stitches too?
Yeah, I put 2 corner stitches that just sort of hold the edges of the pancreas sort of up to the jejunum, and then those aren't tied down until the end. You just they're kind of approximating it, and then I put that posterior stitch in that kind of holds the posterior wall.
Sort of invaginate the pancreas into it all, or
it's not really invaginated. It's just sort of bluntly right up against with, and those stitches just take all tension off of the true anastomosis, which is the duct to mucosa anastomosis.
How big of a bite do you take on the pancreas with those stitches? The stay stitches that you place at the beginning. The stay stitches,
I take, a superior and inferior, like a full thickness bite through them.
Like 2 centimeters back?
Yeah, and 1 to 2 centimeters back, yeah.
And what kind of stitch is that? Is a PDS as well?
No, it's just a 3-0 silk.
Uh-huh.
I'm old school. I use a lot of silk. I could probably switch to something fancier, but I like silk.
and then you said 6 or so sutures of 4-0 PDS for your anastomosis. Those 4 stitches that you sort of created the mini stoma, do those get cut and removed as the operation's going?
They just kind of stay in. The way I kind of do it, those are sort of offset, sort of in between the 6 sutures. Yeah. So they're not really on top of each other. It's a lot of suture in a very small space, but they're not on top of each other. All the knots are
going on the inside of the...
No. You don't want any knots on if you can, on the inside of your anastomosis. Okay. Those can be kind of nituses for stone formation.
Okay.
And pancreas duct stones following a Whipple are really tough to deal with.
Sure. Okay, so your knots are going on the outside of your anastomosis. Then you have some 3-0 silks to put your bowel and your anterior board back together. Yeah. Okay, and then anything else on that, or go on to the bile duct?
No, I like that one. Yeah, that sounded like a solid anastomosis.
Yeah, very low leak rate on that one. And then we got to do a bile duct anastomosis on the right lateral superior jejunum. And that one, any tips or tricks?
This one's pretty straightforward. You make your enterotomy, and because this enterotomy is a little bit bigger, the mucosa tends to want to evaginate out, so you don't need to do those stomatization sutures.
Still 4-0 PDS?
Still 4-OPDS interrupted all the way around. Start with the back wall, sort of bring your back wall in with 1 or 2 stitches, and then just go around from the back coming up. And I just lay them all in individually, and then I tie them at the end.
Do you tack that jejunum up to any other tissues around to take off tension in any way? Or
I don't. In training, there were some people that sort of brought some falciform down or tacked it up to sort of that biliary plate, but I have not had a lot of issues with the bile duct anastomosis in that way at all.
Okay.
I think the prevention of leaks after a Whipple is obviously such a hot topic. And there's a lot of things you can do. People have looked at sort of wrapping the pancreatic anastomosis in falciform, spraying it with all sorts of glues and things like that. And very few have had long-term viability of showing that they've improved things. So my leak rates remain sort of the average, and I keep it at that. So,
and then your stomach, your GJ. How do you so you make your GJ not with that limb?
Well, it's sort of, you go back down below the transverse mesocolon.
Yeah.
You measure, maybe another 20 centimeters just so that it comes up easily. Right. I usually do a retrocolic. I make a little window through the mesentery, bring it up that way. You don't want to make your limb too long for a variety of reasons, but one of which is so that your GI doctors can access your pancreatic and biliary anastomoses if necessary. And then it's just I do a hand sewn 2-layer anastomosis, silks on the outside and a running double arm Vicryl on the inside.
Beautiful. And then
I love
do?
hand sewn bowel anastomoses. I think are awesome. I love doing hand sewn bowel anastomoses.
I even just at least close my common enterotomy hand sewn because I can't.
I do too. Even if I do a stapled, common channel, I hand sew that enterotomy at the end.
So when you hand sew that, what stitches do you use?
The common enterotomy after a routine stapled anastomosis. Yeah. It's usually, sometimes depending on how big it is, you can just take a 3/0 Vicryl starting at the crotch up, and then you can almost turn it back around and sort of do a running Lemberted back down to where you started from. But that's kind of taking practices that I learned robotically and applying them to open surgery. But otherwise it's just... Yeah, it's a fun trick. And then, but otherwise it's a running 3/0 Vicryl and then Lemberted individual 3/0 Vicryls. I'm a 2-layer person.
But you don't put 3/0 silks on that?
Well, that's usually because I'm doing it all with the same Vicryl. There's some reasons that, I think for me, the Whipple is the epitome of it ain't broke, don't fix it. So I just haven't really changed that in so long that I'm still using some pretty old school sutures and techniques on it.
Yeah, 100%. Very good. Anything else? So then as you're coming out, do you do anything with the omentum over the top or anything?
No. I used to routinely float NJ tubes down so that they had a little feeding access help. But honestly, I've been getting patients eating faster and faster. And, back in my training, nobody ate for 5 or 6 days after a Whipple. And hopefully at 5 days, you're going home after my Whipple. So I just start feeding them enterally a lot faster.
Mm-hmm. How often? Like when do you let them have clears?
And next day. I probably don't even need to leave the NG tube in that I do because I'm universally pulling it out the next morning and starting them on clears.
And what drains do you put in and where?
I do universally put one drain just running sort of over top of both the biliary and pancreatic anastomoses. I'm always fiddling with my practice as far as routine drain amylases. I think that's one part of a rural practice was convincing our lab to check drain amylases. They said they weren't validated for it, and it took a long time to get them capable of checking drain amylases. Or, the things you don't think about, what's going to be the one big holdup in your pancreas practice, your lab checking drain amylases. They kept sending them all out to Mayo, and they were taking 8 days to come back.
Wow.
So at this point, I check a drain amylase usually on day 3, and then if there's any concerns on day 5 before I pull it out before they go home.
Okay. And just for the sake of completion, how do you close your fascia and your skin?
I use a running OPDS, usually on a CT1 needle, ×2, starting from above and below and closing in the middle, irrigate the wound and close with staples. Pretty same old, same old.
Beautiful. All right.
Wow,
wow.
you really dove into it.
I mean, that's just, I like it. And I cannot believe you went through all of that with me.
I can't believe it. I felt like I just dictated my op note.
So, but thank you. That was
No problem.
For me, it was fun. We only have just two quick hit questions because you already did the other one. Do you have a financial tip for our listener?
Yeah, I thought about this a bit when you said you were going to ask about it. And I have to admit, of all the things that I try to pull off in my practice, understanding the finances of medicine is probably not my wheelhouse. But what I would say is, as a rural surgeon, I think any of your listeners who are in rural practices know that your hospital will continually try to get you to do more, whether it be to take on more clinical work or more administrative work. And if you're not careful, you will be giving a lot of yourself for free. And so my financial tip is really just that as you are continually asked to take on more roles in your hospital, that you understand your worth, and whether or not that worth is money or that worth is time, to not be afraid to ask for what you are worth for that. It was a hard model to come up with a means of being an acute care trauma surgeon who gets paid per shift and be essentially salaried for a certain number of shifts, but continue to want to do Whipples on the side. And how do you figure out how to get paid for that? There was no good way to do an RVU cutout for that. So I was asked to calculate an hourly rate for all pancreas work, including clinic time, rounding time, and surgery time. And that was more challenging than I thought. This only happened 2 years ago when I switched to ACS surgery, and how to calculate your worth. What should you be paid by the hour for pancreas cancer work was really challenging to figure out.
It should have 4 digits. That's my opinion.
It doesn't. But I appreciate that. But yeah, so part of it is like, in rural surgery, you will be handed a lot of opportunities to improve your hospital, to improve care for your patients. And each of these is going to be incredibly demanding of your time. So figure out what you're worth and what to ask for, so that you don't burn out on your job. Yeah,
I love it. And I love that you're saying that it's not always money. It's, and I mean, I do real estate investing too. And I do obviously surgery, and both of them, there's a little overlap in this. It's not always the price. It's more about the terms. So very good.
Yeah, absolutely.
All right. And then lastly is resources for the busy rural surgeon. Do you have any resource that you just think every rural surgeon should know about?
Well, actually, I mean, my resource, I think, is far more generic. Obviously, I could point you at, the videos on the SAGE's website and things like that. I'm sure people on your program have talked about things like that before. I think your greatest resource as a rural surgeon is your referring the surgeons that you are going to refer to, whether that be me or the tertiary center. I think it's very easy as a rural surgeon to feel like every time you have to call one of those surgeons that they're going to think you're dumping on them. And that that's going to breed this lack of communication where all you're ever calling for is when you have to get rid of a patient. And one of my passions dealing with national organizations and the Rural Surgery Advisory Council through the ACS is to kind of create a world where rural surgeons feel comfortable talking to other surgeons and vice versa, and just giving advice and seeing how we can keep patients in, closer to home, in their home hospital system, and that not everything that gets a little complicated has to be sent out. And I think if we can only communicate with each other better, that doesn't have to happen as much.
How?
Because let's face it, we all know. Sorry?
How can we do that? How can we develop those relationships? What's the best, most natural way?
I think from a more national standpoint, I think, just having sort of guidelines of who your referral base is, like who you refer to, who the touch points are there, and making sure that those numbers are readily shared between each other. And then there's the possibility of even dealing with better telehealth between things. So you could be this you could call me on a telehealth system when I'm on call and be able to say I've got this patient. I'm not entirely sure if I need to send them or not. This might just be a routine post-op ileus. It might be something more. And we could kind of talk about what your resources are, what you can do, when to ship, when not to, before it becomes just I need to get rid of this patient.
If I was going to pick you up, you're not going to do pancreas anymore.
Yeah.
You're going to do...
Sounds lovely, honestly.
You're going to do critical access medicine in Mississippi. And I drop you at a critical access hospital. How would you develop those relationships with who is the most important, and how would you go about meeting those people?
I mean, is it so hard just to call people when you're not needing to call them about a patient? I think I would look at the hospital that tends to be where my hospital tends to send all of their referrals. I would call whoever's the general surgeon there, and I'm assuming there would be more than one, maybe offer to get together for dinner and kind of chat about what I'm capable of doing and what they do and how we can help each other. I think when you have a chance to develop those relationships, when it's not being driven by a specific sick patient, it's better to kind of chat about that. And then to also just know that to take it a step further, I think the first time I reached out to the University of Washington and Virginia Mason, I thought, again, that they were just going to think, who's this podunk surgeon trying to do all this stuff out there? And what I've learned is they are just so grateful to have people trying to do things. And they're not there to steal my patients. They are there to keep my patients near me whenever humanly possible. And developing those relationships early and often and not when it's acute is the best thing to do. So yeah, if I was in your critical access hospital in Mississippi, I would ask, where'd all my patients go? I would call the surgery team that works there. And I would develop those relationships. Maybe that means developing a relationship with the GI team, with the IR team. I don't know.
Yeah, it's a lot. It ends up being, so first off, the answer that you gave, which is that your best resource is your cell phone, is actually the most common, on this show. Yeah. And it is the right answer. I mean, there's no right answer, obviously,
right answer. Board's answer.
But it is, I would say, if I had one resource, it would be the contact list too.
Yeah.
But fortunately it's real world, so we don't just have one resource. But two more follow-up questions and then get you out of here. So what would be the essential surgical subspecialties that you would call ahead of time to know? Like for example, Surg-Onc, HPB, what else? General surgery.
So who would I have in my, for lack of a modern term, my Rolodex for these people to call? I would say the ones I would want a trauma surgeon.
The person you're talking to right now is a resident who's going to go find themselves in that situation. And they don't even know that, what you're just saying. And so like for me, the things that I send out, it's like if you find yourself with a bile duct injury, okay, who are you going to call? And like the hernias that you don't want to do, but they still need their hernia fixed and they're going to need to be done at maybe a university setting or whatever. Who's the hernia guy at that place? Those would be probably those two, and then Surg-Onc would be the three most common surgery referrals that I send out. Is there anything else I'm missing?
I would say in my practice where I am, the things that I need to send out the most is complex colorectal stuff, like the low rectal tumors, the complex IBD, the bad anal fistula patients where it's like transsphincteric and they're going to do lift procedures and stuff too. The HPV anal wart patient that's going to need the surveillance with the special anoscopy and things like that. Like I find that I'm sending a lot of people out for colorectal stuff.
And how about
that is more elective. I would say emergently, honestly, it's knowing your trauma surgeons. I mean, everything happens so fast with trauma surgery that you want to have good relationships with those people so that when you call them in a panic, like they know that you're capable. They know what you can do there and what you can't there and why you're sending them somebody. I recently shipped a through and through liver injury. I told you I have a lot of gunshot wounds, but having that trauma surgeon I sent him to on speed dial, being able to not only talk to him in real time about the patient I'm sending him and not just going through a transfer center, but also being able to coordinate follow-up because now he has a bile leak and a drain and he's going to come back to my community and he's not just being dumped there and told to find a general surgeon because I can communicate with that person. I think HPV for the bile duct injuries because those are just so devastating. Those are probably the really big ones. I mean,
Foregut.
Sorry.
Foregut.
Foregut less so for here with my partners, and I think major hernia, I think I've come to appreciate is such a specialized field that, you really have to know, are you capable of doing TARS or not, or do you even want to take those patients on and whatnot?
Something you might find interesting, in 6 years, I don't think that I have once called a trauma surgeon.
Oh, really?
I don't see any trauma because they don't show up at our hospitals.
Okay.
Because if they're really that bad, they ship from the field,
from the scene. Yeah.
And none of the places I'm at are leveled trauma centers. And they're not even level 3. So there you go. But I say that just to show you the difference of what a rural practice. You have a rural practice, 100%. Yeah. And so do I. But they're very, very
different. And I think it's important. Like, we're a level 3. But at the same time, we're hours from everywhere else.
Yeah, so everything in the region's going to come.
Everything dumps down, and then we figure it out and have to send a lot away. I mean, we virtually never have neurosurgery. We only have one head neurosurgeon, and it's only every other week just by daylight hours during the week. So anything else, we can't. I can't remember the last time he did a cranie. We don't have ability to bolt or do burr holes, so they all go.
The other thing I would say is your state Indiana, or your state American College of Surgeons chapter. Mm-hmm. If you go there, you showed up. First off, the person that's an academic surgeon that sees the rural surgeon at that meeting, it says something about you already, that you showed up. You already have clout. You see how, like, the stupid level of questions that I ask you about this specific topic, which I guess I could have prepared more, but that's me training at a HPB referral institution. And I got after it in residency and worked hard and did great on my ab sites and everything and boards and whatnot. And not everybody has the opportunity even to train at that level of place. Mm-hmm. But all you can do is take yourself from the place you are now to where you're going to go and operating inside your sphere of competence, keeping your Rolodex. Thank you for those tips. I just think that's great to elevate the quality of rural surgery that's being delivered everywhere, which is going to help the whole country, and reputation wise, you talk about that trust factor and all that. So
yeah, absolutely. Absolutely.
So thank you for joining me on the show, Cate. I did want to say, did you want to say any kind of plug about the program, what you guys have for the rural surgery med student program? Yeah.
Obviously I'm affiliated mostly with the University of Washington and Washington State University, both of which you have different sort of rural tracks. And I mostly have students who actually aren't from Washington. Currently my students from Montana, I have students from Alaska and all surrounding states. It's part of the WWAMI program, or the Washington, Wyoming, Alaska, Montana, and Idaho program that all tend to rotate through here. As far as the surgeons out there, the residents out there that are looking for future jobs, I got to tell you, we are almost never hiring because we've all been here our entire careers and we all hope to retire here. And we don't have. It's wonderful. It's such a rarity to practice in a place where everybody starts their job there and their goal is to end their career there, and it feels really, really, really good. One of my partners grew up in this town. His dad was a radiologist I worked with. All of his brothers are doctors and are coming back to this town. Like we have a lot of longevity in our program.
So cool. Well, I am so glad that I got introduced to you and that you took the time to come and have this conversation with me. Yeah. I look forward to seeing you through the ACS and wish you the best with everything. So
come to our session on and speak up about rural transfer dilemmas.
Sounds good. All right. We'll see you in September then. So
yeah, absolutely.
I'll take us out. Thank you to the listener as well for being here. This has been the Rural American Surgeon, and we will see you on the next episode of the show.